Hi, this is Brian Wilmers recording a lecture for the upper gastrointestinal system for the medical surgical nursing course. Here are your learning objectives. So the first thing I wanted to cover was oral cavity cancer. We talk about that quite a bit in health and promotion. However, I don't know if you guys have seen much of this. So I broke it down into different categories. So leukoplakia, so remember your leukocells or your whites. So on this one you're seeing the white tongue right here. You got erythroplakia, so remember red is erythro, like your erythrocytes. And you can see this back in here. Squamous cell carcinoma, this one looks like an ulceration. And then Kaposi's sarcoma. And Kaposi's sarcoma is often associated with a weakened immune system or even like HIV and AIDS. Often these patients will have a history of either alcohol abuse or tobacco abuse. And then treatment can vary greatly. Oftentimes we're talking about radiation, chemotherapy, or surgical interventions. Oral cavity stomatitis is an ulceration, and it can be either single ulceration or multiple painful ulcerations. This can be primary from a non-infectious process, from herpes simplex, or from traumatic ulcers. Otherwise, it can be secondary, generally speaking, from opportunistic bacteria or viruses during an immunosuppressant state. Collaborative care on these patients would include getting a good history, any changes in oral habits, oral history, oral hygiene, any drug history. Assessment-wise, you're looking to see the size, color, location of these wounds, where it's at, any drainage, looking at any lymph nodes, and then drug therapy for this. You know, if it's bacterial, you can do antibacterials or antivirals if it's HSV. You can do some topicals, you can do some numbing medications, you can do something that will cover it and coat it. So it really kind of depends on the therapy that they need for the drug therapy. So cellulitis is a salivary gland dysfunction. So basically we're looking at inflammation of a salivary gland caused by either infection, irradiation, or immunologic disorders. So irradiation can be from head and neck cancers that's been treated by radiation. So when they get this, they tend to have really dry oral mucosa. Treatments are going to be pushing hydration, warm compresses to that site, massaging the gland unless you've got destruction of that tissue related to radiation or chemotherapy. Use of saliva substitutes or using of substances that stimulate the flow of saliva, like lemon slices or lemon drops. GERD, generally speaking, most of you have heard of this. This is a backflow or a reflux of the GI contents from the stomach into the esophagus. This can cause some pain and swelling. It also has got long-term effects called Barrett's esophagitis, which ultimately does become a malignant cancer. So clinical manifestations of this often include dyspepsia or heartburn. They have some pain with this. Oftentimes they can have belching or gas or lots of regurgitation, which they can taste. Hypersalivation, dysphagia, dinophagia, chronic cough, asthma-like symptoms, chronic chest pain. All these things can be associated with this. Some of the diagnostic tests that we'll do with this will be 24-hour ambulatory pH monitoring. So they put a tube down, and that's that pH probe that we talked about in the assessment section, where it's got different monitors at different levels to see if they're refluxing, how high does it go, and how acidic is that content. So they wear that down with that, and they can see how many events and how acidic those events are. Other things they can do would be an EGD, so basically taking a scope, and then possibly even taking some samples of that esophagus. So non-surgical management of this is eliminate foods that are causing a decrease in the lower esophageal sphincter, such as chocolate, alcohol, caffeine, carbonation, spicy foods. They really should be eaten small, frequent meals because it puts less pressure on that. Lifestyle changes, so elevating the head of the bed up a little bit, up to about 6 inches for sleep can help. Stop smoking and alcohol consumption, reducing weight. Wear non-binding clothing, so don't have that belt real tight. And then refrain from any heavy lifting or straining, especially after you eat. Drug therapy, we can talk about antacids, which don't stop the reflux, they just make it more neutral. So if they do reflux, that it doesn't cause the damage that it otherwise does. Otherwise, you can have histamine blockers, so decreasing the acid. Proton pump inhibitors, once again decreasing the acid. Prokinetic drugs trying to speed up motility to try and get the acid out of there. And those are some of our major management things of this. We can also do a Nissen, which is basically a surgical procedure to try and narrow that spot, and so you cannot regurgitate up. Hiatal hernias are a protrusion of the stomach through that esophageal hiatus, and so part of the stomach goes up above that diaphragm. You can see in this picture that we've got different variations of this. We've got a sliding one, in which it's like kind of a direct pull, and so you can see this part of the stomach comes up, versus an outpouching when a rolling hiatal hernia comes up and part of the stomach comes out like this. So assessment of this is, do they have heartburn? Do they have regurgitation? Do they have any pain, any dysphagia, any belching? Are signs and symptoms worse after eating or in a recumbent position? Diagnostics for this would definitely be a barium swallow and looking for with fluoride diagnosis. Non-surgical management of this is going to include patient teaching using drugs such as antacids, histamines, like we talked about before with the GERD. Nutritional therapy, so avoid eating late in the evening, avoid eating foods associated with reflux like we talked about. Weight reduction would help with this one, and then also elevating up the head of the bed up 6 inches for sleep. Surgical management of this will be to pull that stomach down and then hopefully try to make this a little bit tighter in here, and so that you don't get that slippage through there again. Gastritis, so can be lots of different things, but we're going to be looking at acute versus chronic gastritis. And so what gastritis is just an irritation of that stomach. So with the acute versus chronic, some of the acute things that can cause this would be an infection, NSAIDs, alcohol, caffeine, radiation. Some of the more chronic things tend to be antibodies to parietal cells, H. pylori infection, surgery, exposure to toxins, and once again alcohol and caffeine. So some of the clinical manifestations of this include abdominal tenderness, epigastric pain, bloating, hematoemesis, which is vomiting blood, melena, which is traces of the blood in the stool, dyspepsia, which is heartburn, and then can actually even go into a shock type of situation. Diagnosis of this would be an EGD, so you take the scope down and get a direct visualization of this. The other thing that we are currently doing is a lot of H. pylori testing to see if this is a bacterial infection that we can treat with antibiotics. So non-surgical management of this would be, primary treatment would be elimination of causation. So if they're related to NSAIDs or foods or anything in particular, stop that. Otherwise, we can start drug therapy, which would include H2 blockers, trying to decrease secretions, put carafate down there, which is a mucosal barrier fortifier, so to coat that and cover that. We use antacids to buffer that hydrochloric acid and bring that pH down, bring it up a little bit to more neutral. We can do vitamin B12. That's not necessarily to treat this, but if your stomach is inflamed, you're not absorbing that nutrient, so that will be a side effect to watch for, is deficiency of vitamin B12. And then we can do treatment of that H. pylori infection. Other things we can do would be stress reduction. Sometimes that will help if somebody's very stressed out and increases stomach acid production, and that can lead into gastritis as well. Surgical management of this can be removed. If it's very severe, we can remove part of that stomach and just bypass it, go straight into the intestines. This is usually not recommended. It's kind of a last-ditch effort. Other things we can do too would be looking at those vagal nerves and do a vagotomy to try and cut those nerves and decrease the amount of stomach acid production. Peptic ulcer disease, this is a lesion of the stomach or duodenum caused when your defenses are down, and this leads into ulcerations as well. So this is very similar to what we just talked about. As we're still looking for H. pylori, we're going to be treating any of these things. If you get a leak here, you can really cause some bad peritonitis, hypovolemic shock, and actually even death. We have to watch for bleeding. We have to watch for all these other signs and symptoms. Always manage your ABCs. And then if this patient is becoming severe enough, you really want to do 2 IVs so that way you can give blood in a quick hurry as well as fluids if you need it. Curling's ulcer, stress ulcers, or Cushing's ulcer, this is just because of high stress events. We're talking about medical crises, traumas, and some of the manifestations are the same as those other ulcers. But just know that the cause is because of the high stress environment, often correlating that along with not being able to eat, not being able to move that stuff down, and not neutralizing that. If you think about some of our sicker patients in the ICU, they're not eating, but they've got all that stomach acid there. We should be starting them on some prophylactic, antihistamine blockers, PPIs, trying to prevent them from getting these stress ulcers. GI bleeds, we talked about this briefly before. It can be from a variety of things. It can be from esophageal cancer. It can become from varices, where the vessels become weak. It can be from the gastritis that we talked about, ulcerations that we talked about, cancer, or duodenal ulcers. So signs and symptoms of this is going to be that dyspepsia again, pain. It's usually sharp burning and gnawing pain. They're going to have a feeling of being full or being hunger. And then probably the biggest thing would be with perforation and a peritonitis, you're going to get a rigid board-like abdomen, which is a big red flag, and you should intervene on that quickly. Intervention for this is going to include 2 large bore IVs, so you can give fluids and even blood products very quickly, and it's probably going to be an intervention such as surgery to correct this, or endoscopy would be another option. That concludes this lecture. If you have questions, please contact your instructor.